Thank you very much for the introduction. So just a little bit of context. So I'm a consultant anaesthetist, like I'm sure many of you are here. I'm also preoperative assessment lead in Colchester, and I'm the PI for PQIP. And the rest of my time when I'm at work, I have an interest in vascular anaesthesia and obstetrics. So the problem, I think, for us as in preoperative assessment has been quite well described. There's a lot of surgical morbidity and provides a lot of work for the NHS nationally, and there's about 10 million procedures that happen each year. About 25% of the population have a long-term condition, and we know that our population, our surgical population certainly are getting older. There was one paper that showed that in 2014-15 there were 2.5 million patients over 75 years old, compared to just less than 10 years before where it was 1.5 million. And of course, these patients, as they get older, will come with more and more comorbidities, which provides us with more and more challenge for our preoperative assessment clinics. Colchester's no different. We have the most deprived area of the whole country in tendering in our catchment area, and 1 in 4 patients over the age of 65 have 2 or more comorbidities in our area. We're a district general hospital, similar number of beds to Guildford. We've recently merged with Ipswich just down the road, so between the two hospitals we serve nearly 750,000 people. I just run the Colchester side of it, and we have a centralised preoperative assessment service which sees over 12,000 patients a year in all specialties with a few exceptions. When I took over as the lead, we decided to do a little bit of a restructure just so that we could make our service more efficient and a little bit more patient-centred. And I'm here today really to tell you a little bit about what we did, and I'm sure many of you have done similar things in your hospitals. And the 2 major things that we did was we introduced an initial preoperative assessment clinic, which I'm going to talk to you a little bit about in a second. And we also introduced a COPES clinic, the Colchester Older Persons Evaluation for Surgery Clinic, to see our higher risk, frail, elderly patients with multiple comorbidities. And the idea is, through these 2 clinics, to provide a bit more of a bespoke service for each patient that's appropriate to them and their situation, the surgery they're having, their comorbidities. And of course, the PQIP priorities from the first annual report were very much part of this. So we wanted to target the things that are particularly pertinent to pre-assessment, so the anemia and the diabetes and the individualised risk assessment. So I'll just show you a little bit about how we did that. So the initial preoperative assessment clinic, so this is based in our main outpatients. It's a walk-in clinic, so when patients get told they need an operation, they go straight round to the initial preoperative assessment clinic, where they get seen. Now, you wouldn't put your most junior nurse on the front door of A&E, so we took the same approach in pre-assessment. We appointed one of our very senior, very experienced pre-assessment nurses to a Band 6 role to lead this service, and really we couldn't have done it without her. And she has a team of nurses, and between them they run this clinic 5 days a week in main outpatients. And the idea is that they triage patients to red, amber and green, where green are the low-risk patients who can have everything done there and then. They get all their information, swabs, blood pressure, all of that stuff done, and then they can just be put straight onto a list. The amber and red patients, it's not time wasted for them. They will need to come back for a fuller pre-assessment, but for them we can identify the things that have been identified as the PQIP priorities and try and sort those problems and a couple of others out early, so that's poorly controlled diabetes, anemia, but also we look for poorly controlled blood pressure and that sort of thing, poorly controlled blood pressure, poorly controlled thyroid function, and RCCG won't pay for people to have joint replacements who have a BMI over 35, so we find them at this stage rather than 2 months down the line, so that we can get them to go and have the treatments that they need. So I'm showing you our results sort of 10.5 months in. This was the results from the beginning up to the beginning of August. We saw over 2,000 patients, so 2,071 patients in this time. The split of specialties is in the pie chart that you can see there, and it's largely the specialties that we see in our main outpatient clinic, so orthopedics, general surgery, urology, and a bit of gynecology. Some of our specialties like oral, ophthalmology, ENT get seen in a separate building. A little bit more challenging to see those patients, but we're working on it. They wait for about 11 minutes, during which time they can fill in their form that covers all their medical details. And then they have, on average, a 15-minute appointment. So it doesn't take a huge amount extra of their time. Of them, about 40% are green, so these patients are able to go straight on, and none of them will need to come back for any further anaesthetic assessment, so that saves them time. And then for the others, who are red or amber, and we have a set of criteria that defines who gets to be green, amber and red, we're able to identify the problems that we can do something about. So we've found 59 patients with anemia, uncontrolled hypertension, 129 patients, BMI over the threshold for the orthopedic patients, 25 patients, and poorly controlled diabetes, 19 patients. So we can be asking their GP or the diabetes service to address these problems, or put them on our anemia pathway at this point, so at the earliest possible point, really. Then the older person's the Colchester Older Persons Evaluation of Surgery Clinic. So this is a clinic for our really high-risk patients. So these are identified either by the surgical consultant at IPA, in the nurse-led pre-assessment clinic, by the consultant anaesthetist who's reviewing notes. And then these, the sort of tip of the iceberg, who are our trickiest patients, come and see a consultant anaesthetist, usually me, with one of our care of the elderly physicians. And we try and medically optimize them. This is a bit of data from our first sort of 50 patients that came through. And you can see that they had changes in medication. They had anemia treatment, IV iron. They had referral to other specialties. And we identified some new comorbidities, actually, things like a new breast cancer, things like that, through this clinic, which needed, some of these things needed sorting out first before the thing they were coming for surgery for. We facilitate shared decision-making, which I think is going to be talked about a little bit later. But some patients we discuss with the surgeon as well and decide to perhaps modify the surgery or not proceed with the surgery that they were due to have. And we make necessary preparations for surgery, so perhaps booking HDU beds, perhaps arranging for the correct personnel, maybe they need consultant-led care, etc. I thought I should put up our PQIP reports, but of course all of this supports trying to meet the PQIP objectives. We have the same problem with anemia as the rest of the country, and I hope that when our data comes out about whether we're actually addressing that, it will demonstrate that we are. I think our numbers suggest we probably are. And we're checking HbA1cs in our patients. Of course there have been challenges, but I'm sure anyone who's done any sort of service improvement will have encountered these. Our poor nurses, so that's Maria there in the lighter blue, have to work in what used to be a cupboard in the main outpatient clinic. It used to be a store for equipment. And I hope that we've got some new building going on. I hope they're going to get a nicer place to work. And I've already alluded to the fact we have clinics in other locations, which is slightly challenging because it's difficult to staff all sorts of, lots of different locations. But the thing that's really made it work is a really committed and experienced nursing team leading this project along with me and the others in the pre-assessment team. The fact that we appointed someone as a Band 6 to lead this has really, really helped. And as was mentioned in the last talk, collecting all the data is really important, and I put a picture of Tracy up there, who has been fantastically compiling an amazing spreadsheet, which has allowed me to present this data to you today. So in conclusion, we've done a little bit of restructuring to try and allow us to give the resources that we need to the patients in a more patient-centered way. So our lower-risk patients who don't want to spend hours being pre-assessed can just have a brief pre-assessment and go away. And then we've got more resource then to spend, I hope, on our higher-risk patients who need much more input. And in this way as well, we hope that we're targeting the PQIP priorities for our PQIP patients, but also there are other patients who benefit from this. The primary joint replacements also benefit from our anemia pathway and what have you. For the future, we're hopefully soon going to digitalize our pre-assessment system, which should make it a little bit more efficient, perhaps help us to capture those more distant sites, and we're hoping to include more of our specialties as they come through. Thank you very much.